Dr. Skander, tell me a little bit, there's been a new, almost like a revolution in ovarian cancer with the use of maintenance therapy. That means therapy that you can give, that you talked about in the previous segment, of patients having gone on chemotherapy and they can be put on this something called maintenance therapy. So tell us a little bit more about that.
So it's certainly an important aspect of treatment now. It's emerged in the last couple of years with approval of these Parp inhibitors. There's 3 FDA-approved Parp inhibitors, rucaparib, olaparib, and niraparib for use in this setting, and I anticipate in the future we may see more approvals. But basically, when we historically, patients with recurrent ovarian cancer, whether it was platinum sensitive or not, would get chemotherapy, and then when they completed traditionally 6 cycles of chemotherapy, they would stop treatment and then initiate surveillance.
Tell me a little bit about what you mean by platinum sensitive.
So the duration of time in which the cancer has gone away from completion of prior platinum therapy.
Okay.
So if they completed their prior platinum therapy and at least 6 months elapsed between completion and recurrence, that's defined as platinum sensitive disease recurrence. If a patient progresses on their prior platinum therapy or recurs in less than 6 months, that's a platinum resistant or refractory patient population.
Okay.
So in patients who have platinum sensitive disease recurrence, the historical paradigm was finish your chemotherapy and then we do surveillance with clinical exams and CA-125, and some people order imaging. Now with clinical trials, all of which have shown very reproducible efficacy using these Parp inhibitors as a maintenance treatment. And what we mean by that is essentially when you're done with your chemotherapy, at that point in time, you don't stop all treatment, but you transition onto this Parp inhibitor, again, like rucaparib or olaparib or niraparib. You initiate that maintenance and you stay on that Parp inhibitor as a maintenance treatment as long as you're responding and or you don't have toxicity that would mandate that you come off of treatment. And that really was driven by several large clinical trials that showed in patients who got the placebo as a maintenance, the duration and time in which that cancer stayed away was approximately 5 months before it recurred, versus in the patient population that got placed on the Parp inhibitor, and this is dependent a little bit on whether or not you had a BRCA mutation in the tumor or inherited or not, but that was essentially 3-fold better. You're talking about 15, 20-month progression-free survival improvements.
Okay, so let me break it down a little bit, and there may be some repetition here, so I'm sorry for that. But let's say you have BRCA, BRCA1/2 negative disease. And when would you use maintenance therapy in that setting?
So right now, you can't use a Parp as a maintenance in the front line if you're not BRCA1 or 2 mutated.
Okay.
But you can if you have a platinum-sensitive recurrence. So the maintenance therapy in the platinum-sensitive recurrent setting is irrespective of
BRCA1 or 2 status. So let's say you had cancer, you had it resected, or chemo after that, and then it came back, and you have platinum-sensitive disease, which is more than 6 months, that they'll be disease-free after the end of platinum therapy, is that correct?
Yes.
Then technically they can get one of the maintenance therapies with one of the Parp inhibitors.
You got it.
Tell me about BRCA1 and 2, the ones who have BRCA1 and 2 mutations, just like Donia here.
Yeah. They would fall into the same basket, but the difference is that when I talk to a patient like Donia who has a BRCA mutation, the data, the magnitude of benefit based on the data that we have appears to be a little bit more pronounced. But I want to highlight something, and this is the really important aspect, is that when we look at these patients who are platinum-sensitive recurrent patients who are not BRCA1 or 2 mutation carriers, again, there's a whole family of genes independent of the BRCA genes that are involved in DNA repair that may have an alteration that's called homologous recombination deficiency. And that also may predict a robust response to these Parp inhibitors. And aside from that, there may be other genes that we don't know yet that may suggest response to therapy, because there are patients who we would call quote-unquote biomarker negative, who still have a really robust and durable response to these maintenance Parp inhibitors. So it's a really exciting option to offer patients when historically we didn't have anything in this setting. And more importantly, we know based on these studies that if we don't offer a maintenance treatment, that average interval of time in which the disease stays away is about 5 months.
Yeah, that's great. So Dr. Hurst, what about if you can delay the next recurrence? Do you think that is what is the impact on mental health of patients, psychological health, if you can delay this recurrence coming back, delay the addition of chemotherapy again?
I think certainly hearing that we now have these options can provide some sense of relief, some sense of control. That, okay, now we're done with this sort of intensive going into the infusion center and getting these chemotherapies. Now we've got this maintenance therapy that's going to keep fighting, can provide a sense of control and relief. I will say that sort of the time period leading up to the next check-in with your physician or the next blood test or the next imaging study, for a lot of folks, is a time of increasing stress and worry. Then sort of build up, can't sleep for several days, and you have the test and you're waiting for the results. Then you get hopefully good results, and okay, then you have this period of relaxation where you can be like, okay, things are okay again right now, and then it builds up again. So there's this undulating experience of stress and that we now have with this sort of maintenance idea.
Donia, do you go through the same? The scan, it's called scan anxiety, anxiety. It's kind of put all of this run together. Tell us a little bit about your kind of experiences, what you go through.
Well, I think I get tested periodically for my CA-125. And so while I'm waiting for that result, yes, there's anxiety because my life could change if it's, it's dependent on a number. And they're always really good to get it to me as soon as they can. So it's been good so far. So.
And then Dr. Skander, how does, when, let's say the CA-125 has gone up or scans show recurrent disease, what is your conversation with the patients?
So it's a conversation that is essentially really tailored around their particular circumstance based on all the things that we've discussed. How long have they been off of chemotherapy? What is the elevation in their CA-125? If they haven't had imaging, is now the right time to do an imaging study to evaluate what is their clinical exam? Because all of these things are going to inform what our options are for subsequent steps of treatment. And one of the things that I think is also important to emphasize is with the adoption of maintenance therapy, by pushing that interval of time out in which the cancer stays away before it recurs, that also gives our patients additional options down the line, where instead of having a disease that's now recurred in 5 months, it's now quote unquote platinum resistant potentially, and less likely to respond to re-exposure to platinum, or patient may not be eligible for a platinum sensitive clinical trial. By going on a maintenance therapy, you can push out that disease-free interval. They're now beyond that 6 months again. It gives you more therapeutic options and really puts you in a spot where really options are key, because that's what we want to do. As you mentioned earlier, it's our dream to either cure patients or turn ovarian cancer into a chronic condition.
Right.
And so if we're able to do that successfully, then we've accomplished a lot.